Hi, everyone. Thanks for coming. My name's Sean Barinholtz. I'm one of the physicians in Andy Pollack's office. Thanks for coming to the EMS series. Certainly on behalf of Captain Goldstein, welcome to Pikesville as well. Dr. Wittberg, do you want to open up with a couple of comments before we introduce?
Absolutely. Thanks, Sean. So I just want to thank the folks from the Hopkins VAD team for coming tonight. And do we have any members from the community with a VAD coming? I saw that in the... There we go. So how many of you have been to either your EMT training program, refreshers, or a paramedic program or refresher, or any kind of high-level program at GEMS and actually had the opportunity to interact with a patient that has a VAD? So 2 or 3 of you, one of which is a physician, you're disqualified. So, you know, this is pretty, I'm preaching to the choir here because you guys are obviously sitting here, but this is uber high content, high quality, top shelf stuff that's being offered here. And you don't get this type of unique, high level, critically important training in your basic EMT course, your paramedic course. And, you know, we in Baltimore County EMS, it's cliche, but we truly are the first link in the chain of care. The assessments we make, the decisions we make, the transport decisions we make, the disposition. I can tell you from working both in the ED and ICU, and I know Sean and Jeff can attest to this, a lot of what we decide to do in the first few minutes and 15, 20 minutes that we're with the patient has a very, very direct and measurable impact on what the ED does, what they think is going on with the patient, where the patient ultimately winds up getting admitted to in the hospital, and has very, very long-lasting effects. So I just want to commend everybody for being here tonight, for being part of this, and for being smarter and engaging in lifelong learning. We obviously have people in the community that have VADs. I know of I've responded to a 31 box where there's a patient with a VAD. These patients are out there, and kudos to you for being here and knowing how to take better care of them. I want to say thank you to Sean Barinholtz, one of our fire surgeons, CAR 609, also a member of Pikesville, and the Associate Medical Director for the Volunteer Firemen's Association, for putting together this very, very high quality lecture series that I really wish that more of both our volunteer and career providers could be at. So I won't talk too much longer, but I wanted to let you guys all know that we are working on forming a strategic alliance with partnership with CCBC, their EMTP program, Emergency Medical Technology program, to bring this lecture series to a broader audience by perhaps rotating the position of the lecture between Essex, Catonsville, and Station 32, by perhaps using some of their auditoriums that have more robust teleconferencing audiovisual capabilities. We're looking at getting the lectures that Sean has recorded and cataloged into a more robust IT platform. If you are in this room and you have a card from the state of Maryland, you'll know that Maryland subscribes to the NCCP renewal recertification process. There's 3 buckets of hours you have to get CEUs for: national, local, and individual. I actually did an audit with Rich Schenning and Danielle Natz this week of all the prior lectures that Sean has put together and all the future, and every single one of those lectures can be put into one of those buckets towards your recertification. So for years in Baltimore County, I've been involved since 2011, we've been talking about internalizing the ALS refresher, and in essence this program does that. You can pretty much get all of your hours for your refresher through attending this program. So we're going to work out the details of this alliance, but I think it's going to make this lecture series, this program, stronger. And like I've said before, when I've had the opportunity to attend and be here, if you have any ideas about how to do this better, how to get more people in these seats, about content, please reach out to Dr. Barinholtz or myself. And I just want to again thank you guys for attending tonight.
Dave, thanks so much. Thanks for the support of this program, as well as making this connection with CCBC. I think that that's really going to help everyone meet all their CME requirements. I think we figured out that in the past year, we've recorded enough content to fulfill 2 years worth of recertification. So there's a lot of content here, so I think that that's going to go well. So anyway, so for tonight, Becky Fioretti. I asked Becky so many times for a CV, like a bio, to describe herself and to share who she is, and she would not give me one. And I think it's because she's exceedingly humble. But what I do know about Becky from talking to some of my colleagues is that you're heavily involved in the coordination of the VAD program through Hopkins, and you are a dedicated educator. So for that alone, I just express unbelievable gratitude for you taking time out at 7 to 9 on a tonight, right after hours, coming to talk to our community. Thank you so much. And you'll introduce your team.
Yep, sure will.
Perfect.
So again, I'm Becky. I've been at Hopkins for 29 years. Most of that was spent in the cardiac ICU. I've been a VAD coordinator for about 8 years now. One of our patients is with us tonight, Mr. Warner, and he's been with us for about, 6 years? 4, yep, and stuff. So head of VAD, works, very active, so he's a great example of what people can do on these devices. In our program at Hopkins, we have about 45 VADs. University of Maryland probably has about the same size program that we do, another 40 to 50 VADs. And then the biggest program in the area is the Washington Hospital Center network. Being part of MedStar, they get a lot of referrals from this area through the MedStar network. They've got about 150 VAD patients in their program, and a lot of those are coming from Baltimore as well. So, an EMS calls come into you guys, it could be from any one of our 3 programs on there. So we pretty much try to keep everything labeled so you know and everything, but it can get a little bit different between practice, between programs. But what we want to talk about tonight is just some basic introduction to VADs. We brought a lot of toys that you guys can come up and play with when we're done. We want to look where the devices are, what's on the market, out in the community, and then talk a little bit to you guys as the front. Ventricular assist device, implanted ventricle to assist and support blood flow. They can be short and long-term devices. Thank you. You're welcome. Short and long-term devices, meaning that they could be just in for a short-term bridge to a transplant if that patient has a potential to be transplanted very soon, or could also be a long-term device on somebody that is what we call destination therapy, and they're going to be on theirs basically until death do them part. The position defines the name, so left ventricular, or LVAD, right is RVAD, both supporting both the right and left ventricle. And then there is a total artificial heart out there. I don't believe any of the programs in this area are doing total artificial heart. I think the closest one is down in Richmond, Virginia, that area. But that's pretty much what we're looking at. And we're looking at durable devices tonight, devices that patients go home with. These are all implanted devices. There's no external blood on any of these devices we're going to talk about tonight, just external wiring and battery power. In the olden days when these things first came out, there were external devices where there was external blood flow. The devices were outside, the body, and a couple of patients over time in many places were able to go home on those devices. But pretty much what we're using these days in the discharge process are these implanted devices. So what are we using them for? Bridge to recovery could be somebody that had a massive MI or some kind of catastrophic heart event, and that they just need some time to recover from that stunned myocardium. So not everybody needs to go to another device, or is going to be they might be able to be recovered. It happens somewhat frequently in your myocarditis in the young population, college students and whatnot, that end up getting a heart infection, and then they're treated for that. A VAD is placed, and a lot of times those people, because they're young, basically healthy before they got that, they can recover and sometimes be explanted from these devices. Bridge to transplant, we're trying to provide support to these patients in order to get them to transplant. The blood O types wait a long time for a transplant, just like everybody does, but they in particular can wait a long time. So this can keep them alive really for years. Transplant. We've had patients waiting as much as 4 to 6 years to get a transplant who are blood type O. And then destination therapy, which provides support just for patients that are aged out of the transplant process, maybe have too many comorbidities, maybe they've had cancer or something else has happened, their kidneys are bad, liver's not great, and so they're pretty much in a destination therapy mode. At Hopkins, our age-out process for transplant is about 71 and 364 days. Once they hit 72, we're pretty much not going to be looking at them for a heart transplant. If they are a dual organ, like a heart kidney, then we're looking even younger, in the mid-60s, to do a dual organ. So there's, in our program at Hopkins, we are heavy destination therapy. So out of our 45 patients we have right now, we've only got about 5 that are actively listed. So a lot of patients out in the community living on these devices for long periods of time. And this is Kristin Freed, who's another partner from our team. Traffic was pretty bad coming out of the city tonight, so thank you for joining us. So benefits of a VAD implant. So increased end organ perfusion, increased mobility. These patients get out of bed, they can go back to work, they can, live a life, for increased independence, just improving their quality of life. A lot of these patients are just in and out of the hospital with multiple readmissions for heart failure. They can't stay out more than a month, and they're back in for IV diuretics and changing their meds. And this, for a lot of patients, really does keep them out of the hospital. Mitch, you can see, is a pretty stellar example of somebody that spent, a lot of time out of the hospital and doing what he wants to do. And that's where we really like to see that, and that's what our goal is. Cost-benefit relationship, the idea behind, or the hope from Medicare and a lot of the providers when these things, we started using them, was that, it'd be cheaper to do a VAD over the long run than, multiple readmissions for heart failure. And I think that the jury is still out on that because there are a lot of readmissions for some patients, that just have all the complications. We call it all the badness of VAD, where they just, every complication from bleeding to, kidney failure, or they're just kind of plagued with things, and the VAD just doesn't do for their heart failure what we hoped it would. So for some people, they really do can decrease their readmissions. Other people, not so lucky. So I think that's why there's still a lot of debate on where we're going with these things long term. And then bridge to future devices. HeartMate III, which is the latest and greatest that came out over the past 2 years. They just keep getting smaller, the peripherals get smaller, the length of battery time, is extended. And so just a lot of, always working on improvements in these devices. And they're also looking at a fully implantable device where, patients wouldn't have to cart around batteries and all the accessories. And so they're the engineers and the research people of the world are constantly looking for, to make a better device. So VAD recipient criteria, unexpected or emergent heart failure, end-stage heart disease, and they're on maximum medical management. They've tried, they're under heart failure cardiology care. They've maxed out their meds. They may be on home inotropes, and they're just not working anymore. And so a lot of those people will be moved on to a VAD. Class 3 and Class 4 heart symptoms, which are your more severe heart failure symptoms, basically healthy other than their heart disease. Where they get a full, head-to-toe workup, CAT scans, prostate, breast exams, OBGYN, all that kind of stuff to make sure that there's no pre-existing cancer or anything that might preclude their success on one of these devices. Especially if they are going in as a bridge to transplant, then we definitely want them cancer-free for that. Emotionally stable, well-motivated. They need to be able to handle this themselves because it is a change for them, and they also need to be able to have a support system for the most part. It's really hard to go through this alone, and so we really do encourage them to gather the troops around and see who's going to be able to help them long-term with this device. We like people to be compliant historically with their medical management, showing up for their appointments, taking their meds before they go into this device. Good care team, insurance coverage, and really that the patient wants it. It's ultimately their choice. We offer them what we can do for them, but, they're going to have to decide in the long run whether it's for them or not. So, similarities, all these devices have an external wire exiting the body. They all have controllers, which is where the brains of the operation are, that tells that pump inside what to do. They all have electric and battery power sources, and most of the patients are able to go home. Now in the pediatric population, which Hopkins does do some pediatrics as well, They are most of the time kept in the hospital until they're able to be transplanted. Most of those kids are put in as a bridge to transplant, unless just the bottom falls out and the social, support goes awry and all that kind of thing. But for the most part, would hope to get them to transplant. So the difference is axial versus centrifugal flow devices, which we'll talk about as we go. The peripheral components are different in the different devices. They're slightly different, and that also can be dependent whether they've got any kind of bleeding history or other issues. And then the life expectancy of the pump itself, which is getting better all the time, but does vary from device to device. So both the axial and the centrifugal flow devices are available. They run at a fixed mode, so we fix the speed on the device, and then the rest of it is what their body generates with that speed. It's a continuous flow of blood. They lose their pulsatility, so when your EMS kind of thing where you're reaching for that pulse, not everybody's going to have one, and that's always the big quagmire on these devices is, looking at other signs and symptoms other than being able to get a pulse. You're losing that heart sound too for the most part on most patients, and then they all have to be on anticoagulation. Generally it's an aspirin and Coumadin regimen. Unless they get into being a chronic bleeder, then we have to reassess that all the time. And it's a relatively high INR that we use, anywhere from 2 to 3.5, depending on what their needs are and what their other history is. And then, basically on these devices, the idea, if they're pink and talking to you, do no harm, even if you can't get that pulse, kind of thing. Use your assessment skills is really important. All right, so first one we're going to talk about, and basically the three devices that are out on the market right now that centers are using are HeartWare, HeartMate II, and then HeartMate III. So HeartMate, as far as a device, has gone from HeartMate 1 to HeartMate II, and now come out with HeartMate III. They've been the longest one doing these durable devices. HeartWare is a smaller company, and so not been on the market so long, and so it has they haven't gotten out to their second generation device yet. HeartMate II is both approved for bridge to transplant and destination. Is only FDA approved for bridge. HeartWare is approved for both bridge and destination therapy. So that is a lot of whatever the patient is going can sometimes decide what device they're going to end up with. So this is the HeartMate II device. Sorry. So you've got your blood flow coming in from your surgeon cores a hole in the left ventricle, sewing ring on here. As blood drops down from the left ventricle, is pushed through these stators and then back through a Dacron graft that's sewed back into the aorta. So it creates just a continuous flow device, and this is an example of what we consider to be an axial flow device. These little guys sort of guide the blood in there, then it spins it around and on it goes. And so that's the HeartMate II. Here's a real life photograph of what it looks like in a patient. This is not radio peg, so you lose that in the picture, but there is, a returning to the aorta picture there. But this is what you would be looking at, your heart coming out of here and going through the patient. Our HeartWare, which is an example of centrifugal, a little bit different design, smaller. There's you core a whole sewing ring on here, and then blood drops into it, spins it around like a centrifuge, and then propels it back again through a sewn on Dacron graft onto the aorta. This is what it looks like in your radio or chest x-ray on there. Levitated, so it has this little metal or stainless steel ring on here, and so that lifts as the magnets lift it, and it spins around, propels the blood, and then before it shoots it out through that Dacron graft. This is the HeartMate III, which is the newest one on the market. It's another centrifugal pump. This is what it looks like. Again, it's very similar to the HeartWare in its appearance from a distance, but what they did with this one was and how this, the wire that comes off any of these pumps is basically threaded through adipose and muscle in the abdominal wall, and then it comes out a stab wound in the abdomen, right or left, depending on surgeon's preference. Sometimes what these do, because patients have these devices for a long time, these wires, the external portion of them can break down, and so people get driveline fractures and they have to get repairs and that kind of thing. So what Thortec did, or Abbott now, as they are with this device, did a modular driveline. So what they did was create an external portion that exits the body here, and then there is a modular piece here. So the hope would be if a patient had a driveline fracture, that it would be, out here somewhere, to where we could just replace this piece out here and not have to do like a whole repair. A lot of these are, tend to break at these, what they call this bend relief or something, where they get fractures down, and so a lot of the kinks and what happened there. So if you could replace just a piece of it, then you would save the patient a lot of trauma, with having to go through that. So that was the idea of HeartMate 3. It's a pretty good design. The only thing that it is for a patient for a struggle, and what you would want to consider as an EMS provider, is this driveline is very heavy. So when patients are wearing like straps and everything to keep it adhered to their body, but when you're moving this thing around, it's a fairly long driveline and it's fairly heavy. So you just always have to watch your wires when you're moving the patients from floor to stretcher or whatever that you're doing. Example of what the internal, this one they consider fully magnetically levitated. Again, the magnets pull it up and it spins around just like the HeartWare. What they're finding in this device, which is an improvement over some of the previous devices, is they're not clotting off like the HeartMate 2 and the HeartWare devices have done. They've had zero, last statistics I saw, they have had zero pump thrombus with this device. They have not saved patients from all the bleeding complications and other things that happen to them, but the patients do not seem to be clotting their pumps off. And they're about over 2 years into utilizing this device, and so that's pretty exciting that we're doing that. All right, this is what the driveline looks like. You can see that little stab wound coming out of the abdomen. This is what a HeartMate 2 driveline looks like. Very similar on the HeartMate 3. It's a silicone wrapped wires, about 6 wires, and they're tiny little wires that communicate what the pump inside to that controller on the outside. And so patients have to do meticulous site care to that. Their goal is to try to minimize trauma to that site, because this is really the Achilles heel of any of these devices, is this wire that's exiting the abdomen. We have lots of patients that developed, or a fair amount of patients develop chronic infection because of this wire coming out of their abdomen. So it can mean months and years of being on IV antibiotics and still in and out of the hospital, still, dealing with that chronic thing. So from the get-go, we, teach them meticulous care in the hospital before they go home, and ask them to just continue that for the life that they have this device. That I will, cheat on Mitch here, that is the one thing that he has had, and as well as he did get a driveline infection, and so it happens to even the best patients, can still get them. So here's all your little system controllers that are out there. So this was generation 1 on HeartMate 2. We're now upgraded. This one had no, couldn't see any numbers, everything. They had to have a separate display. Now we've moved on to a better controller. This is called the pocket controller, and on this little face, using this little button, you can bring up all their numbers, their flow, their speed, their, what they're doing, how many watts that they're using to run it. It monitors, gives us all that kind of information. There's auditory and visual alarms with these guys, and it records events from the patient's perspective too. This one holds about 240 events historically, so when we see patients in VAD clinic, we're able to see, what they've been doing, any badness that they might have done, as well as just things that could indicate problems with them and their heart failure in the device. This is the generation 1 of the HeartWare. Pretty much this one is pretty much obsolete, almost off the market, is being used, and we've upgraded to the 2.0. And the only change in this one was just changing the housing on the ports here from a plastic to now a metal to try to increase some durability with that. And then your generation, or your HeartMate 3 controller, basically you can see from a device, Abbott just kind of swapped the color. We've got blue on white here and kind of white on blue here, just so we can differentiate them on there. But basically all the parameters that between these two devices are very similar on there. All right, so what does it tell us if we look at what we've got? So this is a lit up face of a HeartWare controller. Patient here is running at 3,000 revolutions per minute. That's his speed. That's a set thing. He can't do anything about that. We have to manipulate that in the hospital. Gives him 5 liters of flow, and it takes 4.5 watts, or 4.8 watts to run it at that speed. This is an example of what you're going to see on both a HeartMate 2 and a HeartMate 3. You will get all these numbers on the face of that pocket controller. So if you're in there picking up a patient and you're maybe talking to the VAD center or whatever, and they're asking you, can you give me the rundown on what their numbers are? What's their flow, what's their speed, what are they doing? Then you can get all these numbers off that pocket controller and give them. You do have to light it up, which is what makes it different than this one, which is basically there all the time for your visualization. All right, battery power. So this is the sample of the HeartWare battery. This is the HeartMate 2 and HeartMate 3. They both use the same battery on there. HeartMate 2 and 3 last a little bit longer, 12 to 16 hours. They get out of a pair of these guys. HeartWare is a shorter acting battery, generally 4 to 6 hours per battery, but out of a pair of batteries, you're going to get that 7 to 14 hours or so out of a battery. They all have to require a separate battery charger, and we talked about that LED display that you can light up there, and then the system controller tells them when to change their batteries. So these batteries, once they get down to the end of their 12 to 16 hours, then it gives them little alarms to tell them when to change their battery. And then we do recommend that patients don't sleep on the battery. They all have the capability of having AC outlets for when they go to sleep at night. The alarms are a little bit louder, just gives them better backup so they're not having to wake up every, on this device especially every 6 hours and change out their batteries on there, so they have an AC adapter. This one is a little bit different in the sense that it drains one battery, then drains the other. This one drains the batteries simultaneously, and you'll kind of see that when we hook it up to the controllers on that. All right, so why these patients call, the EMS. It's a lengthy, long list, but basically dizzy, fainted, fell, they could fall down the stairs, they could just, get dizzy, fall, hit their head, clunk it on the nightstand. Stroke, confusion, mental status changes, that could be related to infection. It could really be related to a stroke. It could be related to an INR that's 8, super therapeutic, and now they're having a head bleed, so there could be many reasons for any of those things to happen. AICD firing, so a lot of these patients, I would say maybe 90% of them have an internal defibrillator. So that thing fires once, and then it fires again, and then they're probably calling you, to come get them to figure out why this thing is firing. And that would be a recommendation that we would have for them as well. We want to get them somewhere where we can get some labs, check their potassium, arrhythmia, are they having, why did they fire? Shortness of breath, just those heart failure symptoms that are all of a sudden more acute. Maybe they put on 5-10 pounds in the last couple of days and really didn't tell anybody, really didn't call their VAD coordinator. Now they're really short of breath and they're sleeping on 2 or 3 pillows, and they need some help, now more than later. And a lot of times, if they're a single person living alone, they're just going to call EMS, to come and get them because they don't, have time to get a Uber or a taxi or, friend Joey or whatever to come get them. Chest pain, these patients can be ischemics, have history of heart attacks before they got a VAD, and be an ischemic cardiomyopathy, so they may still have bouts of chest pain that they have because of their disease. GI bleeding, I would say maybe not so much a big one for calling EMS, but it's possible. A lot of these patients, we see their hemoglobin drifting down. They tell us they're having black tarry stools, and we're having them come to the ER, and if they can get here, it's usually probably most of the time a car ride, unless they're just so weak that they can't get out the door, and do it, and so they'd be calling you. Mechanical problems with the VAD, maybe they did a controller change out, the thing's still alarming, they're getting low flows, they can't figure it out, we can't figure it out, so, you got to get to the ER so we can be under our care and figure out what's going on. On all those like little Dacron grafts that come out of these pumps, they can twist and kink over time, so we've had to do, patients all of a sudden great, doing fine, living their life, and all of a sudden just low flow, low flow, low flow, and we're saying, okay, drink more water, what's going on, are you dehydrated? Doesn't fix it, and so we bring them in, CAT scans, x-rays, and we find that the graft is actually kinked, or it's got surrounding it with clot or something that is impeding their flow, and so they have to, at a bare minimum, have to go to the OR and get that piece changed out, if not a whole pump exchange. Just like any of your EM overdoses, maybe they ran out of their meds and they can't get to the pharmacy, so they might call you for that. Get their electricity turned off. This does not get them a free free ride to not pay their bill, so they've got to, keep their bills paid and whatnot, even though we provide them with electric priority forms, but they've got to keep the bill paid or the electricity can be turned off. We've had people lock themselves out of the house and call EMS because, the phone was in the house, they had no ride, no buddy, nothing they could call, and so they just call EMS to come to the hospital. Maybe they were kicked out of their house, had a fight with their girlfriend, she locked them out, they can't get in, they might call you guys. Auto motorcycle accidents, these patients can drive. If they're healthy like Mitch, and are out there doing their thing, they get to drive, even if they have a defibrillator, so they can go back to driving. And then just random acts of stupidity, anything that you guys see out in the field that you would qualify as that can happen to a VAD patient. We had one young couple that were out, drinking and, carousing one night and had a fight, and she pulled on his Driveline and, and it just went downhill from there. So, you never know what these people can do. We've had people, in other centers, you hear stories where people clipping the hedges and somehow got the Driveline, in it, or the kid scissors, the cat ate it, the dog chewed through it. There's just really lots of things that can happen. So when they lose that connection of those wires, they're can be in pretty dire straits on there. All right, EMS considerations. So, scene safety, you guys know about that. Wear your gloves. And assess the patient. Are they talking to you? Is their speech clear? Are they oriented? They know where they are. Are they warm? Are they well perfused? I don't know where they are, who they are, why they're there, what's that. The only thing you can really know that if they're awake and talking to you, at least there's perfusion. Now, whether there's impedance in that perfusion from a stroke or something is possible, but you're not, even if you can't feel a pulse, you're not going to jump on the chest of somebody that's awake and talking to you. Get your EKG on there, see if they've got any rhythm or arrhythmias. Listen to the chest. You should hear, anytime you put a stethoscope on these patients' chests, you're going to hear a hum. And you're going to hear that hum of that pump running. And if there's no alarms, nothing on the VAD is alarming, and your pump is running, then there may be other reasons, of what's going on with them, that they fainted or fell out. And connect with the family. All these patients, from whatever center they come from, generally have, if not a wallet card, they've got like a travel case that has, we ask them to keep their med list available, some kind of brief history about them, and then what VAD center they are. And most of their equipment is generally, labeled in some way, with like a sticker or something from the center that has the emergency 24-hour pager of whatever center that they're coming from. So if the family's all in a dizzy and they can't come up with that number, then, look at the equipment, and that'll give you on what's, VAD center to contact if you need help. Like I had said before, they're on aspirin and Coumadin, so we run their INRs at least 2, so they can, have bleeding events that occur that could have them, need EMS, but just if somebody's called you and said that, I fell down the stairs and clunked my head, then, we want them to go to the emergency room and get a CAT scan right away. Even if it's Thanksgiving Day or whatever, they need to go get checked out, because there's a fairly, high incidence of patients developing subdural hematomas and that kind of thing if they really have a good clunk to the head. So we want to err on the side of safety on that, and so we'll ask them to get to the emergency room and get checked out. CPR is generally a last resort, if you've just got no evidence of circulation. They're gray, their lips are gray, there's no pink, you can't feel anything, you can't, get any kind of response, then if they're basically dead, then you've got to do CPR, And a lot of times, you may get called to a scene where you clearly walk in and it's already rigor mortis, kind of thing. They died on the toilet, or they fell out and nobody found them till the next morning, and they're basically cold and dead, kind of thing. And that's a whole different story than somebody that the wife just called, oh, he just fainted on the floor and X, Y, and Z happened. A different scenario there. So there's really nothing for you to do other than call the more the whatever guy, coroner, at that point to come get them. All right, so you want to inspect your patient. Again, are they pink, warm? Are they gray and dusky? What's their cap refill look like? Can you palpate a pulse? Can you get any kind of blood pressure by cuff? The most accurate tool for these patients is a Doppler and a manual cuff, and I know that I hope as these devices maybe become, more common out there and EMS centers get, more used to it, that there'll be some consideration of having a Doppler, on the ambulances. I don't know if we'll ever get there, but, it's a cheap tool, to have, and it's really, nice when you come upon a VAD patient to actually be able to get a blood pressure. Now with HeartMate 3, they are a little more pulsatile, so there has been a little more success of being able to get, a blood pressure in the field, might be 70 or something, but, a lot of times they can be assessed, and it tends to go maybe a little bit more along their symptoms, to where if they called and, I just don't feel good, or I've been dizzy and I almost fainted, kind of thing, and, I've got a fever, so it might be that they really do have a pulse or a pressure of 70 on there. And then assess for, if the VAD is alarming, see why the VAD is alarming, try to work with the family if they have they have good battery power, is there anything, are there powers, are they using more power, are their flows dropping, just kind of work with the family and see, is this normal for this patient, or is this totally different than what his numbers normally run, and that may be, more of a reason to get these patients to a VAD center, if you can, if there's alarms that you can't fix by changing batteries and, doing everything that the family knows how to do, and you've talked to us and we can't help you with that low flow that just won't go away, is to get them to an EMS center. The hum in the chest if the pump is running, and then just make sure again that controller, is awake, that they're not sitting there on dead batteries, that you've got parameters that you can see, that everything's attached, or they're on AC power. So the patients, again, I said multiple times, are high risk for bleeding. The pump flows will be decreased in a hypovolemic situation, so if they're dehydrated or they're bleeding, their flows are going to be probably lower than where they normally run. Also, the pump flows can go down if they're hypertensive. So if you're actually getting maybe a real pressure of like 110, 120 on these patients, and that's kind of hypertensive for a VAD patient. We generally like a mean arterial pressure on these patients that's less than 90, and on some of the devices we even have it down to 85 on there. So it makes it a little bit hard to get that cuff blood pressure to assess. Go ahead, always check for a pulse, see if you've got anything, normal pressure, give it a try, but with ears, chances are pretty slim of being able to get it. You've got to, assess color and other things as you go, but if they're unresponsive, you got no flow, nothing, again, initiate your ACL Pulse protocol. The EKG is totally separate from the VAD on these patients, so they can just have a normal sinus rhythm, they can have a VTAC rhythm, a VFib rhythm, they could be an AFib, any of your arrhythmias, they can have, and if their defibrillator didn't defibrillate them out of whatever happened, even though they were shocked, then your EKG can tell you what they're in. It's not unusual in somebody who's reasonably hydrated, got decent pressure, to be awake, alert, able to talk on a phone and be in VFib on these devices. They have a pretty a good ability to keep patients going who do go into what would otherwise be a lethal arrhythmia for most of us. And then to defibrillate, you don't have to disconnect anything on these devices. Just put your pads on and go ahead and defibrillate. The only thing we would ask is, because the pump kind of sits right under the left breast, is go a little bit laterally with that gel pad, that you're not defibrillating right on top of the pump on there when you do that. So things to do for transport. You want the controller, should be on battery for transport. If they're hooked up to any kind of AC power, they power for transport. And then just be careful as you're moving them around that you've got the bag and everything close to the patient's body. with his controllers, his batteries, utilize the family. Our caregivers are there to gather up equipment, extra batteries, their backup bag, their backup controller, all that stuff needs to go with them. And we beg you to please take it in the ambulance because, it can't go with their spouse to come in the car later. It needs to go with them at the time of transport. It just will save a lot of aggravation all around if they've got that with them. We'd like to see at least, 2 to 4 batteries along with that backup controller. And most of one of the companies that's a pretty nice camera size bag that we use for all the devices, and most people either have like a small backpack or a small bag that they kind of just a backup controller lives in there. They throw in some extra batteries and they're on their way out the door. But we ask that you please bring that with them. And then, if at all possible, I know protocol dictates this, but, if you can bring them to the VAD center that implanted them, especially in being here in Maryland, with Maryland and us, it's best to try to get them to their implanting center. If it's not that they, if it's different than, like, I don't know, stub their toe, broken leg, something that, might not be so related, but eventually somebody's going to have to go get that patient from the outside, hospital, whoever it is. If they end up at GBMC, then either us or Maryland's going to have to go, get them and bring them to Hopkins eventually. I would say most of the outside centers are not, equipped for very, basic stuff as far as other things, nosebleeds, which are common in these patients. So, they can go to their local ER for a nosebleed, or, we had one lady, cutting vegetables one night, sliced her finger open, so she can go to her local emergency room. That's not something she's probably going to be admitted for. Little things like that, sprained their ankle, whatever, is a lot different than, if they're really having some kind of catastrophic event that they need their VAD center to help them out. I will mention too that we're training around the city more nursing home rehab facilities to be able to take these patients. So right now, Levendale, which is next to Sinai, takes VAD patients. They have taken patients from all 3 centers there, and then there is the Genesis that's up Cromwell, that combination, Genesis Cromwell up there also has takes VAD patients up there. And I think that because of the high degree of destination therapy that's happening with these devices, these patients are living longer on them. We have at least 2 to 3 patients that are in their 80s on our program, and still cooking along. You're out there mowing their grass and, doing their farm work and whatever, kind of thing. And so those patients, unfortunately, the downside of being on these devices and not dying from their heart failure initially is that the dementia that can set in. So Alzheimer's, forgetfulness, those kind of things can get to be a real challenge for these patients. And so we've tried to, train up from rehab centers just to care for some basics on there. But I think that as these patients live longer on these devices, that we're going to see more patients needing long-term care. And I think it's going to kind of create a real challenge around the country of what we're going to do with all these patients that are living on these devices long. There's only so many places that care for them. So that's a challenge that we're trying to at least meet a little bit here in the Baltimore area. So like I said, all the VAD centers have a 24-hour pager number. It's generally on the equipment of the particular patient. Look for that contact number. We're on 24 hours a day, 7 days a week. We're always available to help you triage by phone if you're trying to change out a controller or do something with a patient, or should you do it, or want our help to walk you through it because family's freaking out and they can't remember. Then we're all trained to help you out with that kind of stuff on the phone. So that's all I got. Please, whatever questions I can answer, please ask. Yes, ma'am.
I can't get my head around an EKG on somebody with a VAD because I'm thinking of this circuit of blood that's just going around and around. The valves still work?
Mm-hmm. And their electrical conduction system is still working, so all that is still functioning. you know, and a lot of them, you know, because of some of them have been heart failure patients for years. A lot of times if they've had arrhythmias, you know, just because of their heart failure, then they'll have an internal, maybe a pacemaker AICD combination, you know, so a lot of them, you may have a paced rhythm if they've got a pacemaker AICD combination. Some patients, you know, don't have any kind of defibrillator. The younger population that just all of a sudden had acute heart failure may not have a defibrillator, but somebody that's been on that. But, you know, it's totally separate from the VAD. Their conduction system is still working, you know, their valves and whatnot is still working. The only one that's impaired from a flow standpoint is the aortic valve, because of the pump is, the blood is now going through, you know, the pump, and so a lot of times that aortic valve is only opening once in a while. So that's why you don't get that nice, you know, lub-dub S1, S2 kind of sound when you listen on there, is because it's not always opening 100%.
What difference would it make if they were fibrillating if the circuit is still going? It's not relying on the muscle of the heart to pump, right?
I mean, it contributes.
Sorry. The question was, what difference would it make if the heart was fibrillating, because there's continuous flow, and does the heart muscle play a role in the movement of the blood?
I mean, it still contributes. I mean, we're moving most of the blood flow, you know, through the, you know, Starling's law in effect, to where you've got the, you know, the ventricle still expands from the blood flow as it comes out. You know, not everybody is set at a maximum speed, you know, to where the ventricle is just sucked down and emptied. They still have some squeeze, you know, of their heart. Yeah. Yeah, you know, and the other thing that we have to be careful on somebody that's got a lousy right heart is that we don't return the blood too fast to the right side. Then we send them into right heart failure, you know, so it's a lot of, you know, the surgeon from the get-go is playing to get just the right speed, you know, to get out of the OR, and then over time as the heart, you know, remodels from these devices being in place and things, then they, you know, their speeds, they may need more speed over time, or when they got to get out of the OR, their speed is really low, you know, just to give them some forward flow, but they just can't handle on that right side, you know, to have it massively dumping. So it's a gradual process that can take months, you know, to tweak things and get them just right on there, because we don't want them, you know, suffering from, you know, right heart failure even in this whole process as well, where they're peripheral edema and their shortness of breath, and we haven't done anything for them, you know, and they're still, you know, in and out of the hospital. So it's really a kind of a slow process on somebody that's got some biventricular failure on there. You know, some people have a great RV and it's just their left side that stinks, and so you can put in a LVAD, you know, and get them cooking along pretty fast. But if somebody's iffy at all, and so sometimes it's in the evaluation process, if somebody has a really bad right heart, then we have to decide what we're going to do. You know, is an LVAD really going to help this patient, or is it just going to make them worse? Somebody that has, like, there's some, I don't know all the genetics, but there's some things like giant cell and some genetic kind of diseases that kind of attack the whole heart, you know, and there's a lot of antibodies and things that are created as well, so you know, their whole heart is bad, and a LVAD won't be enough, so they may need an RVAD added to it as well, and still not be a candidate for transplant because they just have too many antibodies. So, you know, there's I don't think there's, you know, we've had one combination with us in another hospital where we did a BiVAD, but, you know, we don't do them a lot. You know, a lot of times what the surgeons will do, they'll put in the long-term device on the left side, put a temporary, which are like things like you might have heard of Tandem or Centromag, or your shorter-term devices, and they put them on that side to kind of get them out of the OR, give them some days to get the stunned myocardium to kind of, you know, rejuvenate and relax, and then, you know, hopefully get them off that temporary device and they can just be on the LVAD on there. Yeah.
You said it's not uncommon for other LVAD patients to be in there and talking and, you know, ventilating well.
Mm-hmm.
If they're ventilating well and the blood is there, it's common to do it. Are they using it alone?
I mean, I think that maybe would be something you want to talk to your implanting center, you know, about, kind of thing. If you're allowed to, you know, like generally that something like that, we're going to give them sedation or something in an ER to try to make it as comfortable process as possible. You know, that may be left up to like EMS protocol. I mean, I'm not sure, you know, but it certainly can be done, but I don't know that, you know, whether.
If I was on the other end, what do you guys think? If I was on the other end of the line, somebody was meditating, right? Why would you possibly put them at risk by shocking them and free up the lead?
Yeah.
Things could go from pretty good, okay, to
Well, the reason why I'm saying this or thinking this is not, you know, I think we've all had patients that are thinking
Right. And that's possible, and that may be something that would happen in transport, you know. I think the other consideration a lot of times also in the hospital setting on these patients is they're generally going to try to do like a transthoracic echo or something just to make sure there's no clot that we're going to start sending through the body when we defibrillate them. So that sometimes can be something that's, you know, better done in a center if you've got time and they're not crashing and burning, you know, right before your eyes, is to let the center or the emergency room kind of, you know, get an echo down there and make sure that we're looking good and that it's safe to defibrillate and we're not going to give them a stroke on the other side of the, you know, so on that. Anybody else? Yes, sir.
Is there a contraindicated to use the Lucas device?
A what?
A Lucas device, mechanical CPR. My thinking is that the VAD system is not flexible.
Yeah, I mean, I've heard those.
I'm thinking it might be a gentle CPR, the smooth contact
Yeah.
CPR versus this and carrying.
Yeah, I would be kind of really leery of putting that, you know, big old, you know, thing on there, because the biggest fear of any CPR is dislodging the device, you know, the sewn-in device, you know, and having like tamponade or something, you know, and stuff. So, yeah, so that's probably not, you know, just do your good old, you know, hands-on CPR on that.
You said there are 3 centers?
University of Maryland, Johns Hopkins, and Washington Hospital Center. And that's just because of the whole MedStar network. And they do have, they're not implanting VADs at Union Memorial, but they do have like a satellite outpatient clinic there. So, so they are all over the area from different centers on there, on that. On that.
We're asking questions of these patients still susceptible to be CHF patients. So how are we going to go managing all these things like anyone else? And I guess we know so they often might do basically CPAP if that's possible, as long as they're at some place called a heartbeat, you know. Hospital. And so I guess the goal with LVAD patient is, as long as they are showing some type of signs of life, we need to put it aside.
Yeah, I mean, I had one last year, and it's like, got sick of it, just passed out, and he woke up, and he was down, and he's trying to get there, then this is there, and it's like, you didn't tell me you had a pump, and I'm like, I mean, I have medical problems, but it's like, you have all that.
All right. And a lot of times that can, like what happens between the time they call EMS and the time you get there, things can change in the sense the patient, you know, stood up, fell out, you know, DFO'd kind of thing, and then, you know, they call you, and by the time you get there, patients, you know, kind of been laying on the floor, woke up, you know, having something to drink or whatever, you know, kind of thing, and may have never had a low flow alarm, may have not ever got to that parameter, because like if somebody, like what are your flows? Like
4 and 5.
4. So Mitch's flows are 4.5. Well, the low flow alarm on a HeartMate II is 2.5. You know, so you've got to really drop your flow in order to start setting off those alarms. And so a lot of times patient will recover before they haven't had, you know, 3-4 days of diarrhea and been vomiting and can't keep a thing down, and you know everything is just, you know, crappy, and now they're fainting. You know, they do in those kind of situations much more than an overloaded heart failure patient, you know, can tolerate little bits of fluid. So we ask you not to flog them with fluid, you know, 250, 500, you know, kind of gently, you know, tight, you know, drip in fluid, or, you know, little boluses, you know, if you're trying to, you know, get a pressure up, or, you know, treat their dehydration, you know. But we can also sort of send them over the edge sometimes. And the other way, if we're dripping in two liters of fluid over a short period of time, we can send them into worsening heart failure.
The problem was actually, Hopkins was like 3-4 days early, he got a nosebleed, so he stopped his Coumadin. And I said, well, did you start it again the next day? No. Well, did you call your center? No. He was clotting off his pump. So he wanted to go to the hospital center. I was like, no, we're going to just take you to Hopkins real quick, and then they can heparinize you and figure it out from there.
Right.
But that was his issue.
Yeah, and that's always, you know, patients, like, you know, all of us always want to kind of treat themselves, you know, and so a lot of times, you know, if it's the nosebleed or whatever, the, you know, GI bleed, and they don't want to come to the hospital, they'll stop drugs and, you know, try to treat it themselves, and then they get into pump problems. You know, we're so, like, judicious that once that INR, you know, drops below 2, we're like, you know, freaking out, you know, putting them on Lovenox, admitting them for heparin, you know, kind of thing, just because these pumps still do have, at least in the HeartMate II and the HeartWare, still have a fairly regular incidence. You know, a couple of patients a couple of times a year is enough, you know, clotting off their pump. So, you know, we just really start, you know, being aggressive with that, you know. So we want them to tell us, you know, if they're having bleeding problems, you know, if they're having nosebleeds, there's other things that we can do, you know, because the sad part about these pumps, for all the great they do with the heart failure, the bleeding complications do, for some patients, just always plague them. They can't get away from it. And the part of it is both in the nose and the GI tract is what they call these AV malformations, you know, because you don't have that regular, you know, pumping action through the vessels anymore. It's just, you know, those arteriovenous things start to malform, and so they pop and they start to bleed, and you know, then patients, you know, gotta come in, gotta stop all their anticoagulation, or, you know, get them a colonoscopy, get them an upper GI, you know. And we have patients that it keeps like moving along, or it's in, a lot of times it's right in the duodenum where they, you know, the stomach contents and all that drums in, and it just seems to be a really commonplace. Not so much gastric, gastritis once in a while, but a lot of times by the time that they're pooping black stool, you know, it's an upper, you know, small intestine kind of bleed on there. Less rare for patients to have, like, you know, bright red blood coming from the rectum. Most of the time it's days of dark black tarry stools. You know, sometimes we find it just randomly on labs. You know, they're getting their regular labs, and they were, you know, hemoglobin was 12 last month, now it's 8, you know, and you start playing 50 questions and you find out, oh yeah, I've had, you know, black tarry stools for like the last 5 days and stuff. Some patients know it. They know it so well that when I start feeling weak and tired, and I know my hemoglobin's down, and we have one, about a 78-year-old guy that we've had to totally take off aspirin and Coumadin because he just could not stay out of the hospital, you know. And so you ride the decision of, you know, risk of clotting the pump off versus just this miserable life of just being in and out of the hospital. So sometimes we do make the choice with the patient that, you know, if they're willing to take the risk, you know, being off anticoagulation, and then we just follow their labs a lot closer and make sure that we're not seeing any signs on their labs that they're clotting or forming clot. Yep.
Is it still rule of thumb that if for any reason if the pump stops, that you want to
On that, yeah, I mean, find somebody just randomly, like, I don't know, patient, you know, family member comes into the house and finds the patient kind of, you know, laying on the floor, pump alarming, you know, kind of thing. It kind of really depends, I guess, on how long it's been, you know, kind of thing. If they just literally kind of like walked out of the room and, you know, heard the thud or whatever, and, you know, and now the thing's alarming, then at that point, you know, we'd say, okay, we'll get them batteries, let's do a controller change out kind of thing. But, you know, there is always the risk of restarting it if we don't really know how long they've been down, you know. So sometimes it's like, you know, patient family wanted everything done, wants to be saved, then, you know, you kind of go and do what you got to do. And, you know, if it's a thing where, you know, you have to withdraw care later, then, you know, then we have to deal with that. But it's not always, you know, a cut and dried, you know, answer on there. You know.
Could we have Mitch do a show and tell?
Yes, absolutely. Mitch, why don't you tell them your, oh, I'm sorry. Yeah, go ahead.
Question.
Yeah.
Can you transport them via helicopter through the atmospheric pressure if you have somebody that's got to bleed with that pump? Or should it go versus
Yeah, I mean, I guess it, depending on if they need to get there the quickest route, they go for it. I mean, you know. Yeah, I mean, I really don't know. I haven't heard, you know.
Yeah.
You know, yeah.
The height at which MS flies is little to no atmosphere. Under 800 feet, yeah, there's no shapes in any question.
Yeah, so. All right.
Helicopters, no communication to helicopter transport.
I saw one day years ago. They were reductive. They were up in helicopter and came up from the reservoir up and go out of all the camp and started bleeding severely. Wasn't the implant for that. I mean, but
It's another mechanism. I mean, there's centrifugal pumps.
Yeah.
I didn't know whether.
And a lot of times if we have somebody go down like on the eastern shore or something like that, that needs quick transport, they're going to life flight them up here, you know, kind of thing. So farther they are away, the quicker ride they're probably going to get, whatever that, you know, is, can be on there. But generally all, you know, these patients can travel by plane, train, you know, as they live their life, can go on cruises. You know, they can do pretty much whatever they want. You know, the only thing that they can't do as far as living their life is submerge in water, you know, so tub baths and jumping in the pool, jumping in the ocean, you know, hot tubs, those kind of things are out. But they're provided with equipment to be able to take showers. You know, they just can't, you know, like submerge in water. So Mitch, why don't you come on up and kind of tell them your story and show them about your device. Mitch has the HeartMate II. So, you know.
So are those both batteries or?
Yes.
Okay.
One of the things that you learn real quickly is how you're going to wear your equipment. Like Becky was saying, they give us a bag that's got all of our spare gear in it. When we first leave, we actually have a sling bag. Everything just kind of hangs in like a little fanny sling bag. Can you give Mitch the mic?
Yes, absolutely.
Okay, so but yeah, like I said, once you get out, you get a whole supply of different things to wear, and a lot of times people will actually make separate vests, and sometimes they'll have jackets with special pockets tucked in them. Over the last, I'm now 4.5 years on my pump. Was implanted March of 14. When I went in, I was at an injection fraction of 10%. So we've actually been in Hopkins patients for 18 years total. Combated it with medications for 14. When I first went down when I was 23, I had an injection fraction of 15 and was told by the doctor, hey, by the way, your lungs are great, but you need a new heart. So got involved with the cardiac, the CHF team at Hopkins. They put me on a whole slew of medications. That's when Coragonol was coming out. The doctor's like, I want to put you in this study because this is like the miracle drug, and it was. In about 2-3 years, they got my injection fraction from 15 all the way back up to 45. I actually got released to be an entry-level firefighter again. Was driving a school bus again. Everything was, you know, I came back off the curve. And then, I guess, so I've been 4.5 years, so about the 3 or 4 years prior to that, things just started to steadily kind of go downhill over time. you know, I would see the cardiologist. I was like, you don't feel good? He goes, you're fine, take more Lasix. I was taking 160 milligrams of Lasix at a pop. I was a lawn sprinkler. So when we ended up moving to Pennsylvania, we now live in Littlestown. When we moved up there about 5 years ago, I told my wife, I said, I'm starting over. Because I was with Hopkins, but I was out of Hopkins and everything else. So I was like through GBMC and all that stuff in that mid spot. So I told her, I said, we're going to go see all new doctors. And I went and I saw the cardiologist up in Gettysburg. And I explained, you know, I'm not feeling great. I can't make it up a flight of steps, this, that, and the other. And he was immediately worried. I couldn't even tell you his name because I've only seen him for about 10 minutes. He was concerned. He goes, I want you to see a specialist up in York. Okay. I made an appointment for like 2-3 weeks later. From the time it took me from Gettysburg back to Littlestown to get to my office, they were on the phone. Like, the doctor is pissed. He said he wanted you to see the specialist. He meant today. You're being admitted to York Hospital, pack a bag. So I knew at that point that we were about as far down in the bucket as we could get. They got me up there. That's like I said, that's when I was told I was functioning at 10%. They said normally 12% you're on life support. So it's just because I had adapted over such a long time that I was still functional. They tweaked me up, got me put back together, so to speak, long enough that I could take a trip to Florida to get my daughter hooked up in college. And on the way back, that's when my insurance kicked back and said, well, hey, if you go to a transplant center, we're going to cover this 100%. I'm like, Bangladesh, I don't care. Wherever I got to go, you take it 100%. That's where we're going. And they worked it out with Hopkins that I could get back in with that program. And that started this whole process. I saw Dr. Russell, and you know, he left me, but Dr. Russell started this whole process of getting me prepped for the implant through the initial year of tweaking the numbers and tweaking the pressures and the speeds. And 4.5 years later, here I am. I am still extremely active. I still am a firefighter. I still am an EMT. I still do fire police up in Pennsylvania. Obviously, I do not bottle up anymore because this stuff is not exactly heat treated. You know, it would suck to go into a building and have the wires melt because they're not heat rated. But I still do brush calls. I still do rescues. I still have a set of turnout gear. I can't put a bottle on. I'm very active. Work, you know, 9 to 5. Sometimes 5 to 9 in the evening too. It just depends on the night. I'm the fire rescue director for a dirt track up in Hanover, where I'm active on the dirt track with that. So I am one of the other patients. There are times I come to clinic, and as I walk through the door, there's patients laying on stretchers because they had to be brought in by private ambulance to make it to their clinic appointments. So there are both ends of the spectrum.
Are you a candidate for a transplant?
I am. When I first got the device, I was actually destination because I had pulmonary hypertension as well. So we ended up being implanted as a destination patient. Dr. Russell was like, this is a semantic situation because as soon as that pumps in there for about 3 months, your pulmonary hypertension is going to fall off and you're going to become eligible again. Sure enough, like 3 or 4 months later, we went to the appointment. He did the scope and everything else, and he goes, "Yep, you're clear. You're now cleared for transplant." So they transferred me over to Bridged, and I was put into the transplant program. I've been in and out of it. I'm right now status 7, which is, I guess, inactive. I've been on the 1B where I was accumulating time. Right now I'm juggling a BMI issue. So if I lose, I think I'm like down to like 6 more pounds. But if I get my BMI at the right level, I go back to being 1B, and then I'm actually back into the eligible. I haven't lost any time, it's just I'm not accumulating any time. I am O positive, so I am one of those guys that says, yep, I might get one 10 years from now. You just never know. And that was kind of the juggle that occurred when we were at that 10%. You know, we went to Russell and we said, okay, what are our options? They said, well, the option is you get a heart transplant, but you are in absolutely every poor category you could be in. You're a male, you're O positive, your size, you know, everything that could be wrong, I checked that box. I said, okay, what's the next option? Get this LVAD put in. Okay, what's my other option? Pick out a box. That's where I was. So it was like, well, it's not a hard decision. Let's put this pump in. We'll give this thing a shot. And like I said, I was one of the ones that kind of bounced back pretty good from it. So 4.5 years later, everybody keeps saying, well, why don't you just get the transplant? Well, when this got put in, I was 36. You know, everybody's like, well, get the new heart. It'll solve all your problems. I'm like, well, no, it solves some problems, but it opens up others. You know, you could be lucky and get 30 years off of a transplant. You could kick a nun and get 10 years off of a transplant. So at 36, I'm like, as soon as I get that transplant, I've pretty much signed my death certificate. I know that in 20 years I'll be dead. Unless you win the lottery twice. And we all know how hard it is to win it first time, you know. I could easily be on the transplant list 4, 5, 6 years before I'm high enough on the list that I get one with my demographics. So the goal right now is, yes, I'm in the program, but I'm not actively looking for one. So right now, for me being status 7, it doesn't really affect me, because my thought is I'm going to run this thing until the wheels fall off, and then we'll worry about trying to get the heart put in. But then, you know, they're coming up with all this new technology. You know, they are. Talking to the lady from Thorotech, they've got the fully implantable one done. They just can't figure the batteries out. You know, we have it now where you can take your phone and stick it on a plate and it'll charge it without hooking any wires up. That's the technology that they can do implanted. But the problem is, what happens when you put it on that plate? It gets hot. So if they do that over the skin, it burns the skin. That's the big thing that's holding up the fully implantable. So you don't have all this stuff hanging off of you and wire coming out and everything else. You know, the decellularization of the organs, I'm watching that real heavy too, where they can take your heart, strip it down to the the core, take my stuff, put it on there, and then when they put it in, they're putting in my heart. Some of the technology, you know, she's got one of the original diaphragm pumps over there. And in the process of learning about what it was going to be, I saw the old original air-powered diaphragm pumps. It was saving people a lot, but the problem, what they were finding out, is they needed to have a lot of transfusions, because as much as that pump was pushing the blood through the body, that diaphragm was actually crushing the blood cells. So yeah, granted, you're pushing it around, but if it's not an intact cell, it's not doing its job. So just going from that technology to what I have, and then into the HeartMate 3, you know, it's getting better every time. So like I said, had I had this situation initially when I was 23, I'd already been gone. But the medication got me 14 years. Hopefully this gets me another 5 to 10 years. Who knows what technology or medicine will be in 5 years from now. And that's my hope.
So you have 2 batteries on right now. Are they backup?
No, they both drain at the same time.
Oh, okay.
On mine. On the HeartWare, they drain one, then they drain to the other. The beeping you're hearing is me being low on power, but we'll take care of that in a second.
So you had mentioned your BMI and you know, desire to lose weight. And you had mentioned in your presentation that above a certain map, the impeller rotor may slow down a little bit. Is there any physiologic variability? So if he gets on a treadmill right now and wants to, you know, jog a mile or two, is there any compensation or ability to monitor? Does anything change
just whatever the native heart, contributes to it, kind of thing. It doesn't, like, there's no, whatever speed they're set up, that's the speed they're set up, and that's what they're going to run at. The only thing that you're going to get is more, blood flow, pushing through that pump as the heart rate goes up, and, more blood, being pushed on there. But a lot of times, when we do, like, practically every patient-free heart failure workup has a stress test at some time, and what they find on the stress tests after VAD is most of them, it doesn't really do a whole lot for their ability to do more on the treadmill than they did before. Their VO2, all that kind of stuff is really about the same, which is kind of an interesting phenomena. Tests that we think will help us, don't always, from diagnostic, but but certainly, I think some people, at least over the time that they're on the VAD, they can do longer on the bike. Most of the mess that we do post-VAD are on a bike, as opposed to like a running treadmill kind of thing. And so a lot of times patients that are like Mitch that are keeping themselves active and going about their life can get more time, on the bike and stuff. But, maybe his numbers may not really, show a whole lot as far as the breathing part of it kind of thing. Yeah.
So I don't want to make this too complicated, but that brings up the question that I have about, most pacemakers now are rate responsive, right? So they're DVDR. So it senses the patient's increasing metabolic demand and it adjusts accordingly. It seems to me as though that the same technology could be used to sense into increased flow, for example. But are you saying that there's no benefit of that because of the underlying cardiac function that's going to respond to increasing demand anyway?
No, I mean, I'm just saying with what we're as they are right now, there, we don't see like a huge differences in, the numbers that we get on a MESS pre or post versus pre-VAD, kind of thing. But I think that their endurance, is where the rubber meets the road. They can walk where maybe they couldn't walk 50 feet pre-VAD, and now they're out walking miles, whether it's outside or on a treadmill. So certainly their endurance, is better, kind of thing. And whether there would be some benefit to like the rate control thing where there was adjustable speed that would respond to their thing. I mean, it's possible. I think that, these VADs, we haven't, engineers don't seem to have come up with something yet, in the 20 years that they've been, making these things. It's more just, smaller and being able to decrease the complications and that kind of thing. But I think as far as changing speed based on whatever the patient's doing, doesn't seem to be somewhere where we're at this point in time, but maybe down the road that they would. So, free if anybody wants to come up and play with them. I do have, we're kind of like oldest to youngest on this table, so on the far left near the door is the XVE, that's the HeartMate 1, that's the big pump that he was talking about, valves, noisy, all that kind of thing. Clotted off was basically a bridge to transplant thing that lasted about 12 to 14 the motor on there, but it's just going to spin around in there. And we don't get quite the good return flow on this that we would on the loop that we have on the other one, so we are going to get some alarms on here. But all of these, both the HeartMate 2 and the HeartMate 3, are all based on a toggle thing. So you have speed as your first thing that you come to, and then you have the flow that's being generated right now for this pump that we have, and then our PI, which is basically what's that ventricle contributing to the whole apparatus, and then the power, which is how much watts from these batteries is it pulling to make the pump run at that speed that it's set at. These pumps run from anywhere from around 9,400 to up to around 10,000 RPMs. So it really depends on what the speed needs. And I'm making a mess here on that, but that's your HeartMate 3. So we're on battery right now, so patients, all they have to do is hit that little battery button that lets them check how their batteries are. There's also indicators on the batteries themselves on there, so when they pull them out of the charger, like Mitch has got his charger set up here, and he pulls it out, he checks it. Right now that one's got not much juice, so that probably wouldn't be one he'd want to put on. He wants one with at least, stuff, so on that. And then If there's patient has something that they do like that causes that low flow to go below 2.5, then they're going to get, things are going to start alarming. They're going to have low flow alarms. On this particular device, the red heart's going to light up on that. And then there's just indicators on here when they have 15 minutes of battery power left, then they're going to get this little hatch mark yellow thing's going to light up. If they let those 15 minutes go where they're on critical battery chargers, then this little guy lights up red on there. So there's lots of bells and whistles to keep them safe on these things, whichever device that they have. And you can see the difference between the 2 and the 3. Basically, all the numbers on the face and everything is pretty much the same, just a difference in the color coding on there. And
one battery? What happens to one battery?
Absolutely, because when a patient is changing their batteries, they're just, I'm sorry, I'm going to just stop this thing from slopping all over the place here.
I'll get some paper towels.
Yeah, thank you. And let me just do it real quick here. So I'm going to use this dead battery here, but basically they're just going to pop out their battery that they want to change. It's still running off the one battery that they have, and then they just pop in their other battery. Everything has arrows and whatnot on it. They do get a disconnect alarm that's alarming, so if they take so long, before they get that battery change, it's going to remind them, hey, you're not done yet. Go ahead and finish the job on there and get that battery changed on there. So, and this one, because I only got one dot, I'm going to get like a low battery on that. This particular device, the 2 and the 3 both drain their batteries simultaneously. Okay, so you change them in sets, but you always only change one battery at a time because they have to have some kind of power source at all times on there. So I'm just going to pull this one out here for a minute. Thank you. Sure. On that. And then I'm just going to shut it off. So what happens, we're just going to do the bouncing balls here. So when we're getting ready to, patient changes out their controller or something, that's how they would have to shut it down on there. But they have their battery charger. Both of the devices have a battery charger that charges 4 batteries, so they can always keep plenty of power. If they know like a storm or something's coming, maybe a hurricane or a tornado or whatever, we ask them just keep everything charged up. That way if you lose electricity, you've still got, maybe 2 or 3 days of battery power that you could get by on, because these batteries are nice and they last that 10, 12, 14 hour mark, and the reason it's so variable is that the speed is variable. So somebody that's only running at 8800 is going to use a lot less battery power than somebody that's running at 9800. So the higher the speed, the more wattage that it draws, the more battery power that it uses. So that's why there's like so much variability in that speed on that. This is the power monitor. This is what they hook to at nighttime. This gives them the advantage of having AC power. And on this particular device, this also mimics the alarms. So if they get like low power or something happen or alarm on the VAD when they're plugged up to this one, not only does the controller alarm, but also the machine alarms. So there is, yep, there is. So if they are hooked up to this at night, they've got 30 minutes to change to battery power, and they get a nice shrill alarm, like to wake them out of the dead of sleep on there.
I in the middle of the night when I look at my clock in the morning and it's flashing.
On that, what's that?
I know I lose power at night if I look at my clock in the morning and it's flashing.
Right, yeah, no, this has like a nice shrill alarm that's going to let them know that they've lost power on there. So they would just undo, from the battery, and they hook up, it's a black to black and white to white. The difference in the wires on this particular thing is the white is what gets the information from the controller onto, like there's this screen, like when they're in the hospital we have a fancy screen that we can get numbers on, so that just gets the data over to there on that. But both of them carry power on there, so that's what that does on that. And then what else? So this is what they call the MPU. This is a little mobile thing that they came out with. They came out with HeartMate 3, and it allows them to, it's just much lighter. If you pick these up, you can see, like this one I can, do a lot easier than I can pick this one up. So this one is nice, just that they're more, more mobile, and they can, travel with it easier to, Mitch was saying, I got to have a huge suitcase to take this thing around, but with this thing, a much smaller luggage. And then
travel with me on the airplane.
Right. All of these devices are they're okayed by the TSA, you know, so the VAD centers generally provide them with a special letter that addresses the TSA that all this is, you know, medical equipment, that their backup batteries and all that can be carried on as carry-on luggage with them, allows them to get through security easier, that kind of thing. You know, we've had patients take cruises, fly, you know, go to Europe, you know, all kinds of things. We had one young man on this particular device that actually worked for in the Obama administration. He was one of the negotiators, you know, with Europe kind of thing, and he would fly back and forth to Zurich all the time, you know. And on this particular device, they have a it runs off either 2 batteries on each side or a battery and the AC adapter. And the nice thing about this thing is you can plug it in like in business class, you know, plug it in a business class outlet and run your controller going across country or whatever. So it's very nice. This one drains one battery, then it drains the other. This is the HeartWare device, and this is what it looks inside, that little tiny pump on the inside, so you can see how the difference that they've come along. This is a later generation than the HeartMate II, which is this guy, this one shows you the whole pump, but this is what that thing is in Mitch's chest, so it takes up a lot of space compared to that little guy, you know, so that's where the technology has really come along, you know.
So this seat's in the left, off of the left ventricle?
Right, yeah, so if this was my heart, grabs onto there like that, flows through here and then returns up there, so you're looking like down in here with your return to the aorta on there. On that. This one is the Generation 1 or XVE. You can see it's just, you know, feel free to pick them up, just a much heavier, clunkier, had valves that deteriorated, you know, so the life of it was not very long. We're both the HeartMate II and the HeartWare have patients that have been on these things 15 years, you know, type thing. So the life of them is pretty long, you know, and I think unless they're destination therapy, they don't particularly have a desire maybe to be on it 15 years, but, you know, but there are some people that are destination therapy and have been able to get 15 years out of it. We had a young lady that had a heart attack when she was 32, you know, she's like Mitch, you know, I'm not ready to get transplanted at this young age, I still got little kids at home. So she stayed on the device for 10 years, you know, then decided, okay, enough complications, I'm ready to get transplanted, and she did, but, you know, all that time, you know, see her kids grow up, go to college, you know, just buys these patients a lot of time, and that's kind of the beauty of it, you know, if they can stay away from a lot of the bleeding and other complications, you know. Again, the Achilles heel of it is the Driveline where it comes out of the skin, you know, and just the meticulous care needed so they don't get infections.
How much of that is actually out?
All of the, like if you look at all this stuff that's wrapped in felt here, this is all what's threaded through the abdominal muscle, all right, that comes through the abdomen. So it comes off, you know, they curl it, comes off, thread it through the abdomen. Then they bring it, they try to bury the nub and then bring it out after that. So all this is your external, yeah. Same thing on the, like the HeartWare, you don't see it on this, but it also has like a felt covering on it, and then has, you know, it's a little shorter Driveline in this device, but same kind of thing, threaded through the abdominal muscle and then brought out to the device on there. Let me just fire this one up so you can kind of see how it works and lights up. So you have your Driveline that comes in here. And right now with no power, doing nothing, so it has to have power in order to run. So once you get one battery on there, that's going to be enough to get it running, and then eventually it will alarm that we're not done. You know, it tells us when, you know, there's low battery on there. So, you know, right now it's running off side 1. Even though it's got 2 fully charged batteries, it picks a side. If I need to drain my battery down and I want to change it, it jumps to the other side. Smart technology on there, still running off that other battery. Will continue to run off that battery even if I plug a new battery over here on that. The only time it would change is on DC power. If I plug into DC, DC always overrides the batteries on there. So I would have one battery and one DC for sleeping at night, is how these patients do, or catnapping or whatever, you know, they want to do on there. These 2 batteries will last in that, you know, 7 to 10 hour range out of the combination on there. And then all the connections are pretty much the same, so the end of that is the same as the end of your DC on there. So once they learn, one connection on a battery, the connections are all the same, So anybody that wants to play with it,
Is this the same
touch
as that?
it. Yeah, they just had a couple, but if you guys want to play with them, please, feel free, to touch them. You can't. The only thing is with these devices, patients have to learn to be gentle. You can't be like shoving it on there, and being careless with it. You want to line it up properly and that it snaps into place. Because patients can, on all these devices, they're this little pin and toggle kind of connection, so those pins have to go in those holes, so that's where the patients have to be careful. So if you're trying to help a family member for transport or something, you just want to make sure that you kind of handle things gently. And
Is this in place?
yeah, and that's because you don't have a drive line in and stuff, so you don't have a patient. So if you want to,
Becky, thank you.
yeah, no problem.